Hello, I'm Dr. Mandaweli, and I'll be giving the overview of epilepsy. So this lecture is not meant to be exhaustive, but it's just an overview of what we're actually going to talk about. It may be more detailed on some slides, but the idea is you'll get an overview of the whole topic, and I'm hoping I can cover everything. So this is the outline of the presentation. We're going to define what epilepsy is, look at epidemiology. We're going to look at the latest classification of epilepsy and seizures, and we're going to discuss clinical approach to seizures and status epilepticus, and also look at epilepsy in special populations. So about 50 million people with epilepsy worldwide, and the higher prevalence is found in low to middle income countries like Zambia. And this is partially attributed to the higher prevalence of CNS infections and of course other factors that are not mentioned here. So the incidence of epilepsy is known to peak in childhood and in the elderly. Now, one thing you should note is that about 8% to 10% of the general population will have a seizure in their lifetime and may not develop epilepsy. So what is epilepsy? So we take the definition from the International League Against Epilepsy. So epilepsy is defined as a disease of the brain characterized by an enduring predisposition to epileptic seizures. So the International League Against Epilepsy gives a more practical clinical definition, and they're actually divided into three. So the first one is that someone has to have at least 2 unprovoked or reflex seizures occurring more than 24 hours apart. So if it's less than 24 hours, that is generally seen as one event. So they have to be more than 24 hours apart, and they have to be unprovoked. Now, a reflex seizure is one which has a consistent provocation that causes the seizure. So like somebody with photosensitive epilepsy, each time they're exposed to light, flashing light, they end up having a seizure. Then the other one is one unprovoked or reflex seizure, and a probability of further seizures similar to the general recurrent risk of at least 60% after 2 unprovoked seizures occurring over the next 10 years. So if they have one unprovoked seizure and the probability of another seizure is at least 60%, then within a 10-year period, that is also epilepsy. You don't need to wait for them to have another second seizure. And then there's the third one is diagnosis of an epilepsy syndrome, like in children where we have childhood absence seizures, in adolescents where we have juvenile myoclonic epilepsy. So when you have somebody presenting with this epilepsy syndrome, they definitely have epilepsy. So what is a seizure? A seizure is defined as a transient occurrence of signs and symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. And one thing we should note is a seizure is a symptom and it's not a disease. Epilepsy is the disease that presents with seizures. So a seizure is identified based on clinical findings. And mostly what we should understand is that an EEG is supportive rather than a diagnostic tool for epilepsy. So now we look at the International League Against Epilepsy 2017 classification of the types of seizures. So generally they're divided into 3 ways: focal onset, generalized onset, and non-onset. And then you have one that is unknown onset, sorry. So then on focal onset, it can be divided into aware or impaired awareness. So I must make mention that this is a new classifications. You'll hear some people using the old terminologies of partial seizures and generalized seizures. So focal onset were previously known as the partial seizures. Of course, you have generalized. and the partial seizures were simple or complex. So now the new terminology is focal onset with impaired awareness or without impaired awareness. And of course, some will have motor onset, others will have non-motor onset. Then there was one that in the old classification that they would say secondary generalization. So this is the focal to bilateral tonic-clonic that you can see at the bottom under the focal onset. So this is where one seizure begins one half of the brain and then it spreads the rest of the brain. So they have a seizure, maybe let's say starts with the arm and later involves the whole body. So that's a focal to bilateral tonic-clonic. And on generalized onset, we have the listed ones there and can also be divided into motor and non-motor. And then we've got a non-onset. Now, sometimes when we're taking history or when a patient presents, we're unable to get the details as to how this seizure started, because that would determine whether it's a focal onset or generalized onset. But sometimes we may not know whether it started focal or started generalized. So that's a non-onset. Then we also have classification of the epilepsy itself. So we have the seizure types, which we've already talked about. And then we come to epilepsy types where we have focal epilepsy, generalized epilepsy. Sometimes we can have a combination of combined generalized and focal, like in children where they have these epileptic encephalopathies. Some may actually have combined epilepsy types, and there's one which we don't know. And of course, we have some epilepsy syndromes that we have, like childhood absence seizures, juvenile myoclonic epilepsy, juvenile absence seizures. We have what we call select. We have the infantile epileptic spasms. And here, the other side is just trying to show us the etiology of epilepsy. So how are we going to approach somebody who comes with seizures? So the goals of seizure diagnosis and management, just generally, you want to determine if the event described was a seizure, because we have to be aware that there are some seizure mimics. And so if you get it wrong, you may misdiagnose somebody with epilepsy and condemn them to lifelong medication when they don't need. And you know that these medications do not come without any side effects. And also, you also want to determine if any cause of the seizures, such as infection, metabolic abnormality, neurological process. So you need to investigate thoroughly as to why somebody is presenting with the seizures. And now in your management, you want to control the seizures, because we know that with every seizure, there's some element of neuronal damage that may end up occurring. Some may have prolonged seizures leading to status epilepticus that may be very detrimental and cause a lifelong disability. And then if you know the cause of the seizure, you want to treat the cause, and so that the person may not come with more seizures. So there are three key questions that you need to ask when someone presents with a seizure. Number one, was it really a seizure that they had? And if it's a seizure, was it provoked? So when we say provoked, we mean, is there a reversible cause? Or was it unprovoked, where you don't have any identifiable cause? And if they presented with an unprovoked seizure, do they have epilepsy? So when we look at somebody who comes with a seizure and you're asking yourself, was it a seizure? So how are we going to know whether somebody is coming with a seizure mimic or an actual seizure? So these are some of the signs that you're going to look for when you're getting clinical history. Some will have a warning before, which is known as an aura, prior to the onset of the seizure itself. So some may come with complaint of a rising sensation in the abdomen. Some may end up, they may notice that they get to have hallucinations. Some see flashes of light. And then when they're describing the seizure event to you, you find that these movements are actually stereotyped. So they're identical or have a minimum variation. So if it's usually tonic seizures where they're having jerking of the right leg and the right upper limb, mostly they'll present like that and not so much of them always changing. And then you have in others may have impaired consciousness, but if you find that eyes are open, then automatism like this where somebody keeps just touching their nose or the button on the shirt. And we have things like deja vu or jamais vu. So deja vu is a feeling of familiarity in an unfamiliar environment, and jamais vu is vice versa. So some have these repetitive movements or behaviors, jerking of the limbs, and then after the seizure ends, some people will have a post-ictal confusion, and then urinary stool incontinence and tongue biting. So when you're taking a history, you have to inquire about all these characteristics that will help you rule out any seizure mimics. So when we look at differential diagnosis of seizures, can come with sudden loss of consciousness, which may actually be syncope. So in syncope, I must mention that sometimes they may have some tonic-clonic movements that can actually throw you off, and you think that it's actually a seizure that they may actually be having. So apologies about the noise in the background. So other presentations of sudden loss of consciousness can be intracranial hemorrhage, and this can also present with seizures actually, and also drug intoxication. Somebody, let's say alcohol intoxication, they can present with sudden loss of consciousness. So we must be aware of that. And then when somebody has sudden neurological deficit, your differentials can also include stroke, intracranial hemorrhage, migraines, and also we have some psychological or psychiatric episodes. So you have to really know the characteristics of seizures so that you're able to rule out all these mimics. So now this slide is generally trying to show this slide. Sorry about that. This slide is generally trying to show us the differences between a seizure and seizure mimics like syncope, transient ischemic attack, migraine, and psychogenic spells. Sometimes it's very, very difficult to tell, and you may actually really need to have an EEG done, which is going to aid in the diagnosis. Remember, we said that epilepsy is of clinical diagnosis, or seizures are clinically diagnosed, and EEG is just a test that will help you, a supportive test that will help you with your diagnosis. So you find that in a generalized seizures, the loss of consciousness is taken 2 minutes. They have this rhythmic bilateral jerking. Some may or may not have an aura, and then post-ictally, some may have confusion or may take time to actually get back to full consciousness or alertness. And we see that it's common when they have urine or stool incontinence. And on injury, one thing when you're examining, you check for lateral tongue bite marks. Sometimes they may actually have bite marks because of the fall caused by the injury and not a seizure itself. So the location, sometimes it's important. So it's lateral tongue bites. They may have soreness or even fractures. When we look at syncope, it's also brief. They may have brief twitching, like I had mentioned earlier on. They may have some pre-syncope symptoms like maybe excessive sweating, palpitations. But the thing with syncope is still they immediately alert, and it's very uncommon for them to have incontinence. Some you may assume they are viewing incontinence. Probably they just had a full bladder when it happened and they ended up passing urine, not that they are incontinent. And they may also develop injuries from a fall. Like I had mentioned, some of these injuries that you see in a seizure may actually happen in a syncope, not because of the seizure, but because of the mechanism of the fall. And the transient ischemic attack, generally, there is no loss of consciousness unless it's in the basilar artery. And they also come with paralysis, but they don't have uh, any of those pre-TIS symptoms, if I can put it that way. And the neurological deficits actually disappear in less than 2 hours, so they return to their baseline, and of course there is no incontinence that is noted or soft injury. Now for migraines, there's some that may actually have auras, and some you find like migrainous hemiplegia where they can have weakness, so they can have a hemiplegia, which is rare, but they won't have any incontinence. Now, those who come with psychogenic spells, psychogenic non-epileptic events can be very confusing, but you'll notice that their movements are often erratic, non-rhythmic, they're asymmetric, and they're not even stereotype movements, so their movements keep are changing. They may actually have incontinence and self-injury, which is possible, but sometimes you see that they are careful not to fall. When they're falling, they're careful to land on somewhere where it's safe for them. So the next question is, was it a provoked or unprovoked seizure? So we have some causes of provoked seizures that are listed. And so when somebody comes with a seizure and you determine that it's actually a true seizure, you need to do your lab work to determine what the cause is or to find out if there's any provocation. So metabolic, so simple things like RBS check. You want to check for any electrolyte derangements, especially sodium, calcium, and magnesium. These are the common ones that can actually present with seizures. And for medications, these are general medications that we may use for different indications, especially given in high doses, may actually induce seizures. And then we have drugs and drug withdrawal. Most common is alcohol or alcohol withdrawal, cocaine, benzodiazepine withdrawal, anti-seizure withdrawal, so or non-adherence. So this is somebody who already has epilepsy and maybe they've run out of medication. So it will be as good as withdrawing the medication. And so they'll end up having withdrawal seizures. And we have systemic illnesses, infections that may actually present with seizures. Of course, renal failure due to the rise in uremia in the blood may induce seizures. Then you have acute brain pathology like a stroke or intracranial hemorrhage, acute head trauma, CNS infection like a meningitis or encephalitis. And then we have what we call PRES, posterior reversible encephalopathy syndrome, usually associated with raised BP or hypertension, and then cerebrovenous sinus thrombosis or critical vein thrombosis. So you have to rule out causes of seizures that may be provoked. And then when we look at causes of unprovoked seizures, we're looking generally at some genetic epilepsy syndromes, which you find that onset is actually in childhood. So by the time they are presenting to you in the adult section, they may actually have been on treatment for some time or diagnosed in childhood. But there are also some unprovoked seizures which are also idiopathic and they come in older adults. And then we have some irreversible brain lesions that may actually present with unprovoked seizures like congenital brain malformation, somebody who's had a stroke before, or history of head trauma, maybe from a road traffic accident or something, or a prior CNS infection like a neurocysticercosis, prior neurosurgery, and a current or a prior brain tumor. So now when somebody comes with a seizure, there are three ways in which they can present to the hospital. So number one, they've had a first seizure and they're recovered and they're coming to you with that history that they've had a seizure. Number two, the patient has epilepsy and they've actually had another seizure. And number three, the patient is actively seizing. So at that time in the emergency room, they're actually in status epilepticus. So how do we handle somebody who comes with a first seizure and they are now recovered? So history is very important. Remember, it's a clinical diagnosis. So you really need a full description of the event, either from the patient or if the patient was unaware or unconscious, you need a witness report and try to make sure that you avoid biased reports of someone saying, oh, I know it was a seizure. Um, you have to really get your own history and determine whether this is a seizure or a seizure meaning. And you want to know the number and frequency of events. Have these events happened before, or it's truly a new event? And you also ask about possible triggers. Do they take alcohol? Do they take any medication that may induce seizures? Okay. So you also want to know, is a patient completely normal? So this is during the ictal phase, are they responsive? Are they not responsive? Ictally also, just general well-being also. When they're not having seizures, what's their baseline? Have they developed any neurological problems like headaches, weakness, visual changes, or any psychiatric changes that may have been noticed? Then if the patient has ever taken medication for seizure, did it help? And if at all they stopped, why was it stopped? And also it's important to look at birth and developmental history because this may be somebody presenting, maybe let's say with the brain malformation and now presenting with seizures. Or events that may have happened prenatally or in childhood at birth are very important because they may also predispose somebody to actually having seizures. Family history is also important, especially close relatives, siblings, parents, and then a remote history of head trauma. So when we come to physical examination, the most important thing is checking for any neurologic deficits because this then help point to a focal lesion. Also, if you're going to look at somebody with probable focal epilepsy, so they may have altered mental state, and then you look for subtle signs of ongoing seizures. It can be something very subtle, as just doing an eye examination, and you see these micro movements. They can have weakness or an asymmetric tone or reflexes. And of course, I had mentioned about checking the mouth for lateral tongue bite. And then initial tests that you may want to do, an HIV test, EEG, and then you can do brain imaging, CT or MRI, preferably MRI, what we call an epilepsy protocol MRI. But in acute settings, when somebody comes with a seizure, CT is very convenient to do and it's faster. So you can quickly order a CT scan, and if it's negative, on a case-by-case basis, you can see if you need an MRI to be done. But of course, MRI is preferable because it's able to detect intracranial lesions that are mostly epileptogenic, and some structures may not be easily seen on CT, but are easily captured on MRI. For example, if they have hippocampal atrophy or some temporal sclerosis that can be captured on MRI, or a very a very small low-grade glioma in the medial temporal lobe, which cannot easily be seen on CT, can be captured on MRI. So now the EEG is able to measure amplitude and frequency of and pattern of brain waves. Remember, these are neurons that are firing abnormally. So you're able to see the recording on the EEG and localize where um, this is happening. And EEGs are most helpful during the event to determine events as seizures. Like I said, for those with psychogenic non-epileptic events, sometimes it may be difficult to differentiate from frontal lobe seizure, which may appear similar, but if they're connected to an EEG at that point when they're having the event, you can tell, you can see if there are any changes in the EEG or it's completely normal while the patient is having that event. And so um, it helps you to determine whether indeed this is an epileptic seizure or a non-epileptic event. So now if the patient has had an event, it's helpful to determine if there are any abnormalities suggestive of a seizure focus. Like for example, in focal epilepsy or focal onset, you're able to see where the seizure is arising from, okay? And then between seizures, when the patient is normal and you're connecting them to an EEG, only about 50% sensitive to find abnormalities. So sensitivity will increase with 2 to 3 repeat EEGs. But there are other things that you can do to increase the yield of the EEG, like doing a sleep EEG or a sleep deprived EEG, or what we call hyperventilation. That's the patient to hyperventilate and you're able to see changes on the EEG. So that you should also note that there are patients who may have epilepsy that can have a normal interictal EEG as you're doing it, and there are some patients who don't have epilepsy who can have some EEG abnormalities. So it's your clinical history is very, very important in this context. So if they have repeated events, you can monitor over days in the hospital to observe EEG characteristics of events. And ideally, a video EEG is best because you're able to see them having the whatever motor features that they have. And then at the same time, they're connected to the machine. So it's easier to make an association. So this is just an example of epileptiform EEG patterns that you may notice. So now, when do you treat? Okay, especially when somebody has come with a first seizure, you don't know when it's epilepsy or not, and you're faced with a dilemma: do you start them on anti-seizure medications or not? And one thing you should note is once you start somebody on ASMs, they have lifelong consequences. So you need to really assess the risk versus the benefits. Like I said, if you misdiagnose, you condemn them to lifelong medication, and they have potential toxicities. So for somebody with the first provoked seizure, there's no treatment needed really. You just have to remove that provocation. And then they won't have any seizures. Somebody with an unprovoked seizure, you have to look at the risk of recurrence in making a decision as whether to treat or not to treat. So we know that first unprovoked seizures are 46%, and 30 to 50% of them, there's a chance of recurring in the next, within 2 years. And the chance of recurrence of a second seizure recurrence is immediately after the first seizure, and it tends to drop off as weeks and months go by. But you expect as recurrence within 2 years from the first unprovoked seizure. And then when they have the second unprovoked seizure, the chance of recurrence even goes higher. So if they have a second unprovoked seizure, you definitely want to treat, and if they even have more than 2, these may actually have epilepsy. So somebody comes with a single unprovoked seizure and they have an increased risk of recurrence. So how are you going to assess risk of recurrence? They have epileptiform abnormalities on EEG. They have a previous brain insult or injury, like a tumor, brain malformation. They've had a stroke before, head injury, loss of consciousness, meningitis, or a history of brain injury. The third one is any abnormal neurological examination. Here you find focal. You do a proper exam and you have focal findings. And then if they have a nocturnal seizure, like a first seizure occurring during sleep. Now the thing about nocturnal seizures is they are occurring during sleep, so the patient himself may actually not know. So when they come with the first nocturnal seizure, it may be likely that they've had other nocturnal seizures without noticing, and they may actually have epilepsy. Now, if they have a single seizure, but they have focal brain findings, you know that there's an ongoing provocation, right? Like somebody with neurocystic psychosis, or major temporal sclerosis, or a brain tumor. So these ones we know that we have to treat. So now the final decision to accept or reject treatment belongs to the informed patient. So you have to make sure that you give them all the information and ask them if they're ready to be treated or not. And counseling is very, very important. So you also need to consider other things when to decide whether to treat or not, like the patient's occupation or how dangerous a second seizure would be. For example, in a mountain climber, a swimmer, or somebody who works for the electricity companies, ESCO, and they go up the poles, you definitely don't want them having a second seizure when they're up the pole. It may be very fatal. The swimmer may end up drowning, the mountain climber may end up. So now also the age of the patient is important, especially the elderly. They are more at risk for harm if any recurrence will occur, and also higher chance of recurrence. So now if a patient has a history of epilepsy and they come to you with another seizure, so basically the questions are similar to somebody who comes with a first-time provoked seizure. You want to know if it's really seizures, or if you want to know the diagnosis of epilepsy. Was it an accurate diagnosis? Who made the diagnosis? Was the cause ever known? And you search for triggers. So sometimes of course, they have epilepsy, it may be all controlled, but they may have something that may trigger them, like an infection or fever. They may also have metabolic abnormalities or electrolyte imbalances, or it's a new medication that have caused that, or they're taking alcohol, they're intoxicated, or they're withdrawing. And medication adherence is something you should actually probe further. Are they taking the right dose? Are they consistently taking the medication? Because sometimes they may run out of medication and it can be similar to a withdrawal, and they present with breakthrough seizures. And also things like sleep deprivation would predispose somebody to having a seizure who has the non-diagnosis of epilepsy. And if they have a diagnosis of epilepsy and they're not on medication, you want to consider initiating them anti-seizure medication. So now the treatment goals in epilepsy. Number one, you really want to control the seizures. Remember, I mentioned that the more seizures they have, the likely damage to the brain that they may have, especially prolonged seizures. So you really want to control seizures. You want to get them to having 0 seizures. And this relies on accurate seizure classification and trigger identification. And then I must make mention that when you accurately classify their seizure, you know how to choose the anti-seizure medication that you are going to give them. And then you also want to avoid treatment side effects. So when you're prescribing a medication, you should know the side effects and you should warn the patient that they may or may not experience these side effects. And generally, you want to improve the quality of life of that person. You want them to live as close to a normal life like the general population as possible. So how are you going to choose your anti-seizure medication? So remember, 70% of the people with epilepsy are controlled on the initial anti-seizure medication. And no single anti-seizure medication is optimal for every patient, usually trial and error. And so it's on a case-by-case basis. It's not a one-size-fits-all situation. So factors to consider when choosing anti-seizure medication, you want to look at the effectiveness of the drug, the seizure type or types that you have classified the patient into, and you want to look at potential adverse effects of the drug, and you want to see if they have any comorbidities. Are they taking other medications? What's the drug-to-drug interaction, if any, with the other medications? And also on comorbidities, you want to see hepatic or renal disease because this has an effect on the clearance of the medication as well. Then age and gender, especially in females. If they have reproductive age, we know that there's some anti-seizure medications that are teratogenic, so you want to also consider that. And also you have to look at the patient's lifestyle and their preferences. So it has to be a discussion. Otherwise, if you don't involve the patient, they may not be adherent to the medication. And also you look at the cost of the medication itself. So general principles of outpatient treatment, you want to start with the lowest minimal dose of the medication and want to take look at tolerability of the medication. So you have to instruct the patient to stop a new medication immediately if they develop any adverse effects, or if a rash, for example, if a rash develops, especially carbamazepine, lamotrigine, phenytoin, and phenobarbital are known to cause a rash. So you may consider that depending on how detrimental the rash may be. Then you want to maximize the dose of one medication before determining if the medication is not working, or if you need to change the medication or add a new medication. I must mention that your target is monotherapy. We try as much as possible to avoid polytherapy in patients with epilepsy. So now reasons to change medications or add a second medication will depend on whether somebody is having inadequate seizure control. And this must be at a maximum dose of the first medication, assuming you've chosen the appropriate medication in the first place, and also intolerable toxicity of the first medication. I mean, while they're on these medications, you want to be monitoring their liver function tests and also full blood counts, because some medications can cause anemia or granulocytosis. So now this gives an example of drugs that have broad spectrum activity. So this is like when you have antibiotics, you have broad spectrum antibiotics, so it's non-specific. So these are the examples, and the ones that we commonly have in Zambia: valproate, levetiracetam, and lamotrigine. Others are clonazepam, perampanel, clobazam, topiramate, zonisamide, and felbamate. Some of these can be found in private pharmacies. And then those with narrow spectrum examples are carbamazepine, phenobarbital, phenytoin, oxcarbazepine, gabapentin, pregabalin, acosamide, and vigabatrin. So remember that you need to determine the seizure type for you to choose the appropriate medication. So this is where it's very important, which drugs works for focal seizures, which one works for generalized. And drugs like carbamazepine are known to worsen certain types of generalized epilepsy. So it's very, very important that you actually classify the patients and consider that when choosing their anti-seizure medication that you're actually going to start. Then you have drugs like efzofitimod, which works very well for childhood absence seizures. I haven't really seen this in Zambia. Not sure if private facilities have this, but generally we end up using valproate for childhood absence seizures. So these are some of the potential adverse effects. So carbamazepine, generally you'd look for a rash, you monitor full blood count, especially granulocytosis and aplastic anemia. Stevens-Johnson syndrome, also a very important side effect that you need to look at. Neurologically, they tend to be very drowsy, dizzy, so it helps if they take it in the evening, early evening, so that they can sleep through the night, and when they wake up early in the morning, they're well rested and the drowsiness has worn off. Lamotrigine, also a rash that may end up becoming Stevens-Johnson syndrome, and also they may have dizziness, tremor, or diplopia. Levetiracetam, mainly it's psychiatric side effects that you need to watch out for. Phenobarbital also may present with a rash, may have behavior changes, valproate, like I mentioned, it's teratogenic in women of reproductive age, so we don't choose it, but you also have to watch out for weight gain, hair loss, granulocytosis, liver failure. And the easiest exam that you can do someone with valproate is to check for tremors. Very, very common. I have seen patients of valproate who present with tremors. Phenytoin is known to cause gingival hypertrophy and also a rash, and they may also have ataxia. Panel also weight gain and also aggression, like some psychiatric features. And then when you're looking at drug interactions, most of our patients may be HIV positive and on ART, or some form of anticoagulation for DVT or some cardiac stents or whatever reason. And then female population may also be on oral contraceptives. So the drug history is very important, and you need to watch out for possible interactions. And most of these anti-seizure medications would either be enzyme inducers or enzyme inhibitors. So you need to know whether you need to up the dose of one drug, either the one they're already taking or anti-seizure medication. And also protease inhibitors. Also, you need to, if somebody is on lamotrigine, you need to make sure that is reduced, otherwise you have toxicity. And factors aiding successful treatment, number one, titration and monitoring. You want to start with a single drug, like I mentioned, and you slowly titrate to a maximum tolerated dose. Now we don't have, sorry. Sorry about that. Apologies for that. So we say titration and monitoring. You want to start with a single drug at the lowest dose that you can start on, and then slowly titrate upward to maximum tolerable dose. And you really need to watch out for any possible side effects. And then when you reach the maximum dose, if they're still having seizures, you want to consider adding a second agent while maintaining the maximum dose of the first drug. And then patient education is very, very important. If you don't involve the patient, most likely will be an issue of non-adherence. They won't take the medication, and therefore they won't have good seizure control. And you must emphasize adherence. They always have to take their medication. Now, the challenge that sometimes we end up facing is the patient may be adherent, but the medication is not available. So it becomes very big challenge. So your advice would be they should not wait till the medication is completely finished before they have a prescription refill. So if maybe they see they have 2 weeks to go, it's better they go for a prescription refill so that in case it's not there, they have adequate time to look for the medication, whether it's acquiring it at a different hospital or buying it from a private pharmacy. And of course, we have to still look at the side effects. You have to inform them side effects. Sorry, that's AEDs should read ASMs because we don't use the term anti-epileptic drugs anymore. We say anti-seizure medication. And then you also tell them to avoid triggers like excessive alcohol or poor sleep hygiene. And then you can ask them to keep a seizure diary. So each time they have a seizure, they can state the day, the date, or the time, the frequency of the seizure that they had. It also helps when they come for review for you to actually see if they are compliant and see if your medication is working, how many seizures they're actually having. And then avoid generic or brand substitution. So sometimes switching brands can actually cause them to have seizures. So try to have them maintained on one particular brand of anti-seizure medication. And now this patient is actively seizing, then status epilepticus. What is status epilepticus? So now, generally it's divided into two. There's the convulsive, where you see the motor symptoms, and the non-convulsive, where they just the patient may just be confused. You can't actually see any motor symptoms. So convulsive status epilepticus, we usually say, if you go to the International League Against Epilepsy and look at its definition, you describe it in terms of 2 time periods. Time 1 at 5 minutes, where this patient is likely to continue seizing, and time 2 at 30 minutes, where neuronal damage is going to occur and they may end up having this permanent disability. So generally 5 minutes or more continuous clinical or electrographic seizure activity is status epilepticus, or they can have seizures and in between they are not recovering or returning to baseline. And for non-convulsive status epilepticus, somebody can be ambulatory and they're just confused patient, or somebody who's critically ill and comatose patient, and you can only see this on EEG to determine the status epilepticus. So this is generally an algorithm on how to treat status epilepticus. When they come, you've determined that they have status epilepticus, you want to initiate emergent initial therapy to actually abort the seizures, and then you want to urgently control the therapy to make sure you terminate the status epilepticus. That is the goal. If they failed on second line, on first line agents, benzodiazepines, you go to second line agents. If they failed, this is probably somebody in refractory status epilepticus. Are you going to use your anesthetic drugs, get them into a medically induced coma? So this is generally the status epilepticus algorithm. And one thing of note is if you're able to terminate the status epilepticus, you need to keep them on a maintenance dose to make sure that they don't have any other seizure, and not just keep them off medications completely, because they may have another seizure and still go back into status epilepticus. And a quick check, what is your ABCs for every patient that comes into the emergency room. And quick checklist, finger stick glucose. We know that hypoglycemia can trigger seizures. Obtain IV access. You want to make sure you monitor their saturations, their blood pressure, and do they need fluids. Then you collect the patient's labs. Remember, you want to really rule out any potential triggers or provocations. And then a head CT scan in case they have any structural abnormalities or any insult to the brain that can cause them to have seizures. And if available, you want them to be in a continuous EEG monitoring. And unfortunately, we don't have this available in our institutions. So initial adult hospital treatment when they come, first line is benzodiazepines, lorazepam, are 4 milligrams IV over 2 minutes. Generally, what we have is diazepam and midazolam. So these are the doses. You can give 2 to 3 doses. If nothing is done, you move to second line where we can use phenytoin or phenytoin, phenobarbital, levetiracetam, and also IV operate if available. If they fail first line, second line, and you have not terminated the status, likely they're in refractory, and you can consider your anesthetic drugs to get them into coma. So what are the goals of treatment in status epilepticus? We really need to abort the seizures as fast or as quickly as possible. And you quickly identify refractory seizures when you're giving these medications and initiate the appropriate advanced treatment. If you're not sure, consult your senior or a neurologist or an epileptologist, and try as much as possible to identify the possible cause and treat it. So this is where your investigations are very important. And then prevent seizure recurrence, like I had mentioned. So once the status epilepticus is terminated, you want to make sure it's controlled by keeping them on the anti-seizure medication. Now let's look at epilepsy in special populations, and I briefly mentioned the women of reproductive age. So pregnancies should be planned and monitored if somebody has epilepsy, because there are definitely risks to the fetus or the child. So in the general population, there's already a risk of malformations. And then when somebody has epilepsy, and they are taking anti-seizure medications, that risk actually increases. And the risk is likely dose dependent and also depends on how many anti-seizure medications the patient is taking. Valproate is widely known to cause neurotube defects. We have topiramate that can cause cleft lip, phenytoin, phenobarbital. So you really need to be careful with women of reproductive age. So when choosing their medication and diagnosis of epilepsy, you need to take that into consideration and try to choose effective drugs that have no non-risk of malformations in the fetus. And drugs like topiramate, valproate, phenobarbital are known to cause fetal growth restriction. Valproate also is also known to cause intellectual disability and associated with autism spectrum disorders. Now, every woman of reproductive age on anti-seizure medications needs to be on folic acid. So it's not just when they get pregnant, but just as long as they have reproductive age, they need to be on folic acid supplementation when they're taking these anti-seizure medication. And then in your history, drug history, contraceptives, you may ask them to consider non-hormonal options like an IUD, because there are some that are liver-inducing anti-seizure medications and may really have an effect on the contraceptives, reduce the efficacy, and the woman ends up getting pregnant. And then fertility may be affected, e.g. evaporate in cases of polycystic ovarian syndrome. Now, in pregnancy, okay, once somebody with epilepsy, a woman with epilepsy, has become pregnant, please keep them on anti-seizure medications, because seizures during pregnancy can be very harmful, both to the mother and the baby. And usually we tend to increase the dose because pregnancy itself may reduce the effectiveness of the seizures, but like this should be a case-by-case basis. And then remember, folic acid is necessitated. Those with new seizures in pregnancy. So if you need to start any anti-seizure medication, avoid valproate, topiramate. Those that are relatively safe, you have levetiracetam, lamotrigine, and carbamazepine. Then in third trimester, sometimes you watch out for eclampsia. It may be eclampsia. You want to treat with Magsil or deliver. Now, when we look at HIV patients, when they come with seizures, you really want to exclude CNS opportunistic infections, because if they have any of those, you treat appropriately. The most common ones, cryptococcal, tuberculosis, meningitis, somebody may have a tuberculoma, toxoplasmosis, primary CNS lymphoma, or a PML. And you also have to consider drug interactions between the anti-seizure medications and the antiretroviral therapy that they are on. So a few examples like phenytoin to decrease the levels of your PIs, valproic acid will increase the levels of zidovudine. And then you have some PIs like atazonava, ritonava, which will decrease the lamotrigine levels. So what are the take-home points from this presentation? You need to understand that epilepsy management begins with accurate identification and description of the seizure type and epilepsy syndrome where appropriate. Treatment is recommended in patients with an increased risk of seizure recurrence. So consider each individual situation. It's not a one-size-fits-all. So there are a lot of treatment considerations that we have mentioned that you have to take into account when deciding whether you treat or not treat a first unprovoked seizure. The choice of anti-seizure medication is based on a combination of drug efficacy, side effects, drug interactions, and psychosocial factors. And then always start monotherapy, start one drug at a time, and you titrate upwards until you reach maximum tolerable dose before considering to add a second drug or switching them to another anti-seizure medication. Remember the special populations, women of reproductive age, and anti-seizure medication. And then identify status epilepticus and initiate treatment emergently. Remember, when we look at epilepsy, time is brain. We need to intervene very, very quickly. These are some of the references that you may want to look up. And thank you so much for attending this lecture. And I hope we can read more around epilepsy. Thank you so much.